So our final speaker for this morning is Salvador Borges Neto. He's a professor of radiology from Duke, and he is, interestingly, not only a nuclear medicine physician, but you're also a cardiologist. Is that right? So he's going to come up and talk to us now about what types of scans there are for neuroendocrine tumor and what their purposes are. Salvador. Wow, you have some groupies.
Well, good morning or good afternoon. We're getting to good afternoon, but now I am on pressure after all these, loud applause and everything. But I'm very happy to be here. I'm very honored to be here. And a little bit about my background, Dr. Howard was talking about. I practiced cardiology for many years. And my career was pretty much, developed through cardiology. I like challenges, and I felt that cardiology was not giving me too much challenges anymore. I'm not saying that there is nothing to discover in cardiology. I still am passionate for cardiology, but I all of a sudden find out that cancer is such a terrible disease that we need to do something about it. And I decided to embark in cancer, and at the time, neuroendocrine tumor was, the FDA had approved the lutetium-177 dotatate. We've been part of the Neto 1 trial, and all of a sudden they stopped treating patients. And I felt that was not right, and I decided to move forward. And I believe we were the first institution to actually start on the EAP, the Expanded Access Protocol. Everybody said, you're not going to get it. I say, I will get it. And that triggers me to be passionate. And I think the patients are probably the cause, the reason why I'm on this. It's so rewarding. I don't think I ever had anything so rewarding in cardiology. The patients became my friends. They all have my cell phone. We talk. We exchange information not only about the disease but about our lives. And this has been fantastic. And I will keep it doing it. So let's talk about imaging. Excuse me. And you might see a little bias towards nuclear medicine imaging, but I think that all the images have their role. There are still a lot of questions out there. When to do it, what kind of imaging, what are they good for? We do have some guidelines out there. Guidelines are changing almost every week. So don't feel like I have to have that scan or I have to have the other scan. Trust me, we still don't know when to do and what to do 100%. It's a learning process, and it's getting better. So conflict of interest, I'm afraid I can treat you, Mr. Fisk. I have a conflict of interest. So that's what's out there right now. But I actually don't have any conflict of interest at the moment related to my speech. So imaging methods in neuroendocrine tumors. So we have a variety. Some imaging are not radiology related, and that's the list. Ultrasound, CT, MRI, somatostatin receptors, endoscopy, colonoscopy. And I'm going to show you one that's not even on that list. But what I'd like to do is to focus on the radiological aspects of imaging those patients rather than endoscopy, colonoscopy, which is outside the area of quote-unquote radiological imaging. So ultrasound, CT, MRI, scintigraphy. We have, of course, the MIBG, which we were a pioneer on that. We've been treating patients with neuroendocrine tumors for over 40 years. Dr. Ed Coleman was the pioneer to treat the first patient with neuroendocrine tumor. And we actually recently published on the Journal of Nuclear Medicine our experience, and which I don't think has been, as far as I know, done prior. We're going to talk, of course, about the somatostatin receptors, and we're going to also address their purposes. And the purposes are very clear. However, again, we just don't know when to do it and what's the best time frame, and sometimes what do they mean depending when you do it. But that's for the diagnosis for sure. It helps the diagnosis. Of course, the diagnosis is just not imaging. You may have learned and listened towards this conference about other means of diagnosing it, which is still not perfect either. It helps treatment guidance. You know, if you move forward, you don't move forward. Again, this is all a puzzle. Everything is a piece. And then you can try to see the big picture. Treatment response, same thing. We look at the images, we see if the images are better, if the patient has improved, but we also need to look at the biomarkers. So again, it's a puzzle that we need to connect all the pieces. And then to follow up, to make sure that things are not coming back. And if they come back, we treat it again. So this is an ultrasound, very sophisticated endoscopic ultrasound. On the left side of your screen is, of course, not what the radiologists do, but on the right side is the ultrasound that corresponds to a lesion. And like I said, ultrasound has a lot of limitations. Now, it's cheap. It's a means of doing something fast, but it's limited. It can help in a sort of urgency circumstances, but it is limited, and not many patients will have ultrasound. But if you had one, that's okay. CT, that's what most people have. So this is one of the classic types. Most of the images actually people target the liver because, as you all know, the liver seems to be the organ that gets all the nasty stuff on it, and people want to know. So the CT has a couple of phases: arterial phase, venous phase, and most of the time, what you see the lesions, when you see the lesions, they are on the arterial phase, which is here. So if someone's going to get a CT scan, I would say get arterial phase, venous phase to be completed. And by the way, everything you see here in white is a lesion, and they enhance peripherally. MRI. It's a beautiful image, MRI. So MRI can tell us a lot, again, about the liver. And what you see was the arrows are a lesion, and on the top, on the A, you can see that the lesion is enhancing, which is not a good sign. That means there is tumor in that liver. The MRI can extend throughout the abdomen, but we don't do whole body MRIs. You're probably going to have to be on the scanner the whole day. So anyway, yes, MRI is very helpful, and there is no radiation involved. But you know, I tell people that if you have something, you got to put the benefits and the non-benefits. And if you need a test that's going to involve radioactivity, so be it. We need to do it. So let's go back, because people talk about CT, MRI, but we are forgetting a lot of things that we still do it. And things that we do have been doing for more than 40 years. I-123, I-131, methiodobenzyl-guanidine, that's the first one. Like I said, the first patient treated with carcinoid from Texas came to Duke, and he was treated by Dr. Coleman. And we image, and then we treat it. That's what they call now theranostic We exist a long time ago, theranostic actually. It's from the time we treat thyroid cancer. That was already theranostic, so we're not inventing the wheels. And I like to call radiotheranostics. Oktar scan, I'm sure you're all familiar with it. That's a somatostatin receptor analog. Gallium-68 PET-CT, the dream. Unfortunately, it's not that available widespread. When I mean widespread, it's for every patient. Some patients can have access. We fortunately can do it at Duke. And FDG PET, which is primarily reserved, we're going to talk about for patients with advanced disease. Just to give you an idea, when the tumors start getting nasty, then they start taking up FDG. And if the tumor is not aggressive yet, it doesn't get to the high grade, then somatostatin analogs will be the choice. MIBG image in carcinoid 40 years ago. So what you see is a whole body MIBG, and we actually can do SPECT, and this patient has metastasis. That's the whole body. It goes through the salivary glands, it goes through the liver, and what we see here is a SPECT showing lymph nodes. The bad thing is that they have disease. The good thing is that that patient can get treated with I-131. That makes a difference here. I-123 does not treat the tumor. It's just for imaging. I-131 is a beta emitter and therefore used to treat patients. Pheochromocytoma and paraganglioma, this is becoming now is an orphan disease. What is interesting is that likewise, carcinoid from the small bowel or the gut and the pancreas used to be orphan disease, not anymore. And now pheo and paraganglioma, that is something that is coming up now, but we've been treating it not with the new drug that was recently approved, and I'm not talking about anything that's unofficial. You probably have heard of it, Azidra. So that's a big I-123 avid, I-131 avid tumor in the adrenal gland. It's a pheochromocytoma. And that patient has also a MIBG study. On the bottom, what you see is just a bone scan. There is metastatic disease to the bone. But if you look at this, it's kind of hard to find out what or look at what it is. A lot of people call nuclear medicine blobby images. So we do need a CT scan, and the CT scan shows there is something in the lungs, and in red, and you can see here. So it's uptaking MIBG. And we can only see in green the liver and the lesion on the cross-sectional imaging that correspond to that lesion here. Again, the good thing is that patient can be treated. He can be treated with I-131 MIBG. That's a patient with I-123 MIBG, and it's a paraganglioma. It's involving the bones. Every dot that you see is involvement of the tumor. The tumor is taking up. It takes catecholamines. This is a patient that we do this frequently. Every time we treat a patient or we image a patient, we image the patient prior to treatment, and here's prior to treatment. And then we take the patient back a few days later, image again, because the dose is much higher. We give approximately 500 millicuries of it. And then we take a picture because sometimes you can miss from the initial images what you don't see after the treatment. Not that you're going to do anything different, but you know what's going on. So like I said, it's going to guide follow-up and what you're going to do down the road with that patient. Neuroblastomas. That's a big tumor. This is a 10-month-old kid, not kid, baby, with a big lesion, neuroblastoma, and the bone skin on the bottom. Again, these patients can be treated by chemo, actually. We have treated patients also with MIBG as well. That's the same baby. And the big lesion in the abdomen, everything dark there is abnormal. Oktar scan, I'm sure you're familiar with it. So this is a normal Oktar scan. So I try to make things like not rocket science, and I also like to show my patients the pictures because they understand. So this is a normal distribution. You see the kidney, you see the bladder, you see the spleen, and that's a normal scan. Now this is a patient with carcinoid on an Oktar scan, that unknown primary. And here's something interesting about these images, that it's very difficult, actually, a lot of times to find out where the primary is. In fact, the unknown primary, you all know, is the second most cause in the diagnosis of neuroendocrine tumor, right behind the gastrointestinal. We believe that most of them coming from the GI tract. But this is, I call, almost pathognomonic. You see that lesion? So that's a lesion right there. This little dot. That's normal, that's normal. That's uptake in the liver, and this is the bladder. And there is a lymph node here, pelvic lymph node, and this is a metastatic disease, a periaortic lymph node. You can see that the images are good, but it's not the greatest, and I'll show you the best ones. That's a patient with pancreatic neuroendocrine tumor with no evidence of metastatic disease. It's fascinating because you see one, you see all, because they all look the same. And the pathognomonic finding is that dot in the middle. That's in the pancreas. In this patient, there is no metastatic disease. That's great. You go up and resect it. Probably do a Whipple. Surgeons here will tell better than I can. So what's the difference between the two? That's an interesting thing that's happening actually right now. About 20 to 30% of patients that have neuroendocrine tumors, 20 to 30, they don't take up somatostatin analog receptors imaging agent. So you can see on CT the lesions. Some, of course, if there is lymph node that are greater than 1, you start getting suspicious. But in terms of physiologic imaging or nuclear medicine imaging, it's interesting that, again, 20 to 30%, and that is actually a study that's going to keep going, hopefully, where patients may take advantage of treating with one and the other, because there is a mixed uptake, if you will. And this is a case, for instance, where a patient has a paraganglioma, and on the Oktar scan you see the lesion with the arrow, but you don't see the lesion on the MIBG study. So some lesions will take up, most of them will take up somatostatin receptors analog, and 20 to 30% will not. And this is an interesting example. This is a pancreatic neuroendocrine tumor. On the left side, you have the Oktar scan. And on the right side, you have the MIBG. Look, it's interesting that the MIBG is going to the bones, and the Oktar scan is going to the soft tissue. So this patient likely will benefit, we don't know yet, to be treated by both, by I-130 and MIBG, or maybe even lutetium 177. PET, that's state of the art. That's what we all would like to do for every patient. Excuse me, I'm going to just show you 3 slides that actually they are a little bit of, what shall I say? It's not a joke, but maybe a joke, but I just challenge the cross-sectional imaging folks in radiology. That's potentially a patient, a brain on a CT. That's a brain of the patient on an MRI. That's the patient on a PET scan. You don't see it because it's not working. So, of course, you're going to see something, but the message here is that cross-sectional imaging don't tell you about what's going on with the tumor. They are great to localize. They are great to help us find out where it is, and we need it. But I don't think they're the one that should dictate it, that's my opinion, what is going to move forward or not. Gallium Oktar scan versus Gallium-68. On the left side, you get an Oktar scan, and on the right side is a PET. I think that you don't need to have great eyes to tell me that the image on the right side is much better than the one on the left. And that is more detail and show you exactly what's going on in terms of the tumor behave. Of course, the pathology is the gold standard. On the top, what you see is an Oktar scan. You can see the images are a little fuzzy. There is a SPECT CT on the B, and the fuse on the bottom is the PET CT. On the left is just the PET, and you can see this photopenic area here. Oops, sorry. You can see this photopenic area here. This is dead tumor. You can see quite well here, actually. But that's a tumor that was treated. And look at the lesions on the Oktar scan here, but look at the lesions here. And when you put the CT together and fuse it, you can identify them very clearly. That's a metastatic disease to the bone. That's lesion is in the liver, clearly and focal. What are the types of scan and their purpose? Keep going. So this is a gallium PET CT on a patient with multiple lesions in the bone, lesions in the shoulder. The liver has metastatic disease. These are periaortic lymph nodes, pelvic lymph nodes, lesions in the bone. Again, it's a very helpful tool. And basically, the benefit is to help stage together with the biomarkers. This is, again, a patient with multiple areas of abnormality on the gallium. Every dot here is abnormal. These are a bunch of periaortic lymph nodes. This is the same image, just windowed differently, with a little bit of lower intensity, if you will. That's the fuse image. And you can tell, you can see why the CT is important. I mean, we can clearly overlap the images, fuse, and then we see exactly where they are, their location, and what they are doing. And it's not in the chest here. It's primarily in the liver. And the CT looks very good and help us identify and localize the lesion. That's a patient with a pancreatic lesion, and thanks God was just in the pancreas, but we can clearly see the lesion on the PET. It's right there, and on the CT we can always see it when we overlap it. No metastasis, surgically resectable. So if we compare the Oktar scan versus the PET. So the Oktar scan is good in terms of accuracy. No question that the PET is superior, particularly to detect small lesions. Lung and bone, no doubts. We can see, lesions at 1 centimeter or even less than that. Convenience. The Oktar scan, you have to come back. Patients don't like it, especially if you live far from the place. The PET you can do on the same day. Radiation exposure, look at that, 12 millisieverts. I think at this point we're not much worried about it, even though people talk. But if you need a scan, you got to have done it. You got to do it. So 12 millisieverts versus 4.3. Unfortunately, the Oktar scan is more readily available, and of course the PET CT gallium is not readily available everywhere for every patient. That tells you how you can stage. This is a slide that was courtesy of Dr. Richard Baum from Bad Berker. I am sure you all know Dr. Bao is a pioneer in PRRT. And you can see that we can clearly, these are different patients. And basically, you can tell this patient is not as bad as this one. This has more lesions and so forth. This patient has actually carcinomatosis. So it's very helpful together with the blood biomarkers. So this was published in terms of sensitivity, specificity. If you do a PET-CT gallium compared to CT only, MR only, and Oktar scan on MIBG, and you can see that it's pretty high sensitivity based on published data. And the reason I'm pounding on this is because it is PET-CT in combination. You can have both. So basically, you can have a regular CT with contrast, a diagnostic CT of the whole body. And on top of that, you can get a gallium-68. So that's probably ideal. Now, if you're trying to identify only liver lesions, they are very small, probably MRI will be the choice, because a dedicated MRI is very good, high-resolution study. So this is interesting. This is a patient that showing you the FDG and the gallium. What you see is basically that the FDG doesn't take up much of the lesion. These are all lesions on the gallium. But when you look at the FDG, only that one, that guy here is the nasty guy. That's the lesion that is taking up FDG, which is not a good sign to have that lesion, because you're not going to treat it, at least with radiopharmaceutical. You're going to have to take, advantage of chemo if all possible. But as it moves forward, you start seeing a lesion on the FDG that's get bigger, and the ones that were seen before that were taking up gallium, they are not anymore. So the disease in this case is progressing. And that's not a good stage. But that's why some patients will have FDG PET rather than gallium if they have a high-grade tumor, and we know they're not going to benefit from PRRT. And that's why it's important. And again, the CT is done together with it. What's the impact in management by imaging? This is all set up. I just put this in there. This is how we do PRRT at Duke, which is quite interesting. After several years, I think we now have a very oil machine. And I just want to show what we've been doing it. So this is a CT scan showing, and you can see that you can treat a patient and it doesn't have the results immediately. You have to wait. And here is a lesion in the liver that starts getting small and smaller, and look at the size. This is just a CT with contrast. It's very helpful. We don't have a gallium here, but it's very helpful. It's simple. You can get it everywhere. It's not gallium-68. And I don't want anybody here to leave this place saying, oh, I need to get a gallium-CT, otherwise it's not going to work. No, a CT will guide us. And eventually, you may find a place where you can get a treatment, if needed, with PRRT and get a gallium scan. But the CT, by no means, can be a first line of choice to imaging, and then you go from there. That's an interesting case. The reason I say is because the CT, you all can see there is a lesion here. And they call this as a lesion and said it was getting bigger. When I do the gallium, I don't see the lesion. The lesion was treated. And on another token, there are other lesions on the gallium that the CT doesn't show. So they are complementary. They are not supplementary, if you will. But the advantage of imaging physiologically, what's going on with the lesion or the tumor, is very important. That's diffuse. So now we know exactly what that lesion that CT saw is. And like I said, it's not taking up gallium, but others are. but that lesion is not. This is a patient from Dr. Richbaum, and basically before and after treatment, 3 years. Wow. Pretty impressive, isn't it? You get treated, 3 years later, you pretty much, I can't see disease on this patient. Now, we're not cured, we are treating it. And the patient can come back and you do imaging to follow up. So this patient is disease-free from the liver. Was the only thing is that some residual uptake I can't see well. We can see very well on the bottom of the picture. There's a small lesion here on this patient. The multiple metastasis, and this is only after 3 cycles. This is a fascinating case also from Dr. Baum. Look at 2008, 2013. Look at how the lesions are going away. He still has disease, but he's in much better shape. The treatment keeps going, working. Don't think that's going to do the job in 3-4 months. Thyroid treatment for cancer is the same thing. So image is important to follow up. And it could be CT, could be the Oktar scan, could be the PET CT, and whatever you have access to it, you should do it. And of course, under the guidance of the medical oncologist. That's a patient from ours, 2 months after the 3rd round. We can see that the lesions in the liver are pretty much gone. There's just a few. This is one of our best responders. I'm going to play this, hopefully, if I could. Can you touch the bottom of the images where there is a dark dot so they can move? No, the bottom. Yeah, there you go. The other one. He came to me like that. That gentleman went to Germany, got treated by Dr. Baum, came back 6 years later. The tumor came back. And he called me. I was doing the extended access protocol. And I put him in. He was actually ended up being close to Steve Jobs. And he's running a marathon right now. And that's what we want to do for the patients. So, if we could summarize, that slide can summarize the types of scans and what they are good for. So there is a role for CT. It has a high spatial resolution. It can pinpoint lesions, can look at small lymph nodes. It may not tell you if they are avid or if they are bad or not. Sometimes they are, sometimes they are not. It can identify the primary, actually, very well. MRI, I would say, is mostly dedicated to the abdomen and liver. The Oktar scan and the MIBG we talk about, they all have their role. And again, depending what we are looking for and what stage of the disease, if it's for diagnosis, guiding treatment, follow-up, each one has its own role. And I think these 3 slides well illustrated that. So that's the message, executive summary about what we just talked. And basically repeat what I just said. Ultrasound has its role, not as much as CT, which can scan the whole body, pinpoint the lesions. MRI dedicated more to the liver. The somatostatin analog, the catecholamines, methiodobenzoguanidine. And I think that if we all can, we will do a PET CT with diagnostic CT scan. And finally, this is a message I want you all to take home. It's important for physicians and patients to realize that direct comparison between somatostatin receptors, PET studies, and other imaging tests are not equivalent. And what happens to be disease progression when you do a somatostatin analog study, particularly PET, may simply represent more accurate stage in disease progression, being confirmed only by comparing like scans over time. So you got treated regardless. If it's PRRT, if it's chemo, and you get a scan, and if it's a scan that is a somatostatin analog scan, and the scan doesn't look that great, don't panic. We need to do scans down the road. We still don't know when is a good time to do it. So one day we will. But again, the message is the studies are complementary, and if the study looks worse after treatment, especially within 2 months, do not panic and wait to get another scan down the road. So this is my team from Rio. He calls Botafogo. It's a zebra stripe. Can you believe that? I was born with that shirt. That was the first shirt I wear. Not that one. That was given to me from my favorite patient. It has the signature of all the players. It's framed in my office. And my friend also did this. See, I didn't know the Beatles were Botafogo. You know, actually I should ask them to play for Botafogo at that time. They probably would do a good job. So, if some of you, I'm not trying to advertise anything, but if someone is in need of something, this is the link to our website. You can find patients to help. You not necessarily need to come to Duke, but they will guide you. If you get that link, you click on it, there'll be phones to call. There'll be people answering the phone. They will help you. If your insurance is fighting, they're going to fight for you. And hopefully, eventually, you get the treatment that you need. It's a new link, actually. Well, it's been there for a couple of months now. So that's my final slide. Thank you so much.